everybody. It is Becky Pearson with Pivot Point of View. I'm joined with my co-host Destri Millsap, and we have the great honor today of having Dr. Jordan Barber on. Dr. Jordan Barber is a pain management expert and acupuncturist, and so we are so excited to bring a different perspective to our podcast and enlighten our viewers and listeners to the different holistic health insights that Dr. Barber can bring to us. Welcome, Dr. Barber, to the podcast.
Thank you, Becky, for that wonderful introduction. And Destri, I'm super excited to talk about a more integrative approach and what we can bring to pain, your horse population, and as well as pelvic floor health.
Yeah, so it was really interesting when we were introduced to you. It looked like the things that you focus on are musculoskeletal issues, pelvic health, and we talked a little bit before the podcast started about some of those issues and how they translate to people that spend time in the saddle, whether it's a bike saddle or a saddle on your horse. How about we start off with your background, where you got your start, and how come you are wanting to create more patient-centered healthcare and give patients actionable steps that they can take to improve their health.
So, Becky, I have a very complex background. I've been seeing patients now for 21 years in some capacity. Prior to from that, I was in IT. So completely unrelated, but strangely, the systematic approach in programming really, I never realized it when I went into medicine, but it really gave me kind of a systemic way to do what we say differential diagnosis and to really look at patients in a very logical sense and not get caught with all the data and make kind of baby steps through. From that, I've ran multiple clinics and have several integrative clinics with PT, medically directed care focused on pain. I have a boutique clinic in Brooklyn where I reside. So I will say with that full disclaimer, I don't see many horseback riders, but that saddle is still a thing with our bikers here. We have a huge biking population. And I originally fell into my first love would be trigger points. And I'm not sure if your audience knows what trigger points are, but they're kind of hyper irritable spots that create referral pain patterns, as well as what we call autonomic phenomena, which is a fancy term to say nervous system dysregulations and sensations like dizziness, vomiting, nausea, ocular disturbances or visual disturbances, etc. And the fascial network, which I got really, really into. From there, I moved into acupuncture for a series of my own health-related issues. And just stayed in that orthopedic world and continued to go down that road and publish in that area. So I have a few publications out specifically on trigger points.
Cool. And so if we were to break trigger points down more, would you classify them as kind of like the knots that people feel? I mean that's one way. Are there other ways that people can be like, "Oh yeah, I think I have a trigger point."
So, I mean, there's the colloquial term of trigger point nowadays. I think we'll say anything that's tender, we'll say is a trigger point. But there is a medical category of a trigger point. They're typically found in very specific spots and have very distinct pain patterns. So when you push on a certain area, let's say your trapezius, your upper neck, if you squeeze in that area in a specific trigger point that's in there, it creates a question mark like pattern up and around your ear and to the outside of your eye. That's a hallmark distinction of that trigger point. And each of them have these different sensations and patterns that do not follow the muscle path, which makes it very interesting. So they can give you pain, like let's say you're feeling pain in your back, but it's actually coming from your abdominal wall, rectus abdominis wraps around. So the understanding of those trigger point mappings allows you to alleviate pain more effectively. And I think it's a major undiagnosed area of pain and pain management.
I agree. I've done some more studying on trigger points as well and their referral patterns. And I think a lot of the things that I've seen help is like sciatic pain for sure. I mean, those trigger points will choke on that. And it could be coming from like you could have pain on the right side, but you could have the trigger point choking on that sciatic on the left side, causing that. And, and working with the baseball population that I have, they might have elbow pain, but they have knots up in the shoulder and stuff that's referring all the way down to the elbow or the medial tricep or whatever. And so those referral patterns are quite interesting and very effective if you can find the areas that actually lock those up.
Destry, you brought up a really interesting thing. So I teach orthopedics and neurological assessment skills to my graduate students. And I make a really big point on sciatica, which we say is sciatic nerve radiculopathy, right? Nerve root-based pain and injuries usually from the lumbar sacral plexus, right? So a lower back injury, using all the fancy words, but basically nerve compression, herniations. And then what we're calling sciatica, right? Sciatic-like symptoms that are really radiating down the side of the leg, which is not the sciatic nerve pathway. And that is often glute medius minimus trigger points that radiate down there. And there's so many people that they'll go and get an x-ray. And this is me kind of maybe moving into that integrative approach. You get the x-ray, you get the MRI, it may show L4, L5 disc herniation, very, very common. But if they're absent all the orthopedic tests to provoke what we say nerve-based pain, and the pathway doesn't match that nerve root, you just happen to have a herniation, which 80% of the population has, that's asymptomatic over, I think, the age of 25 or 26. I think it was like a 2008 study that showed that. Um, we have to actually really pay attention to why a person has pain. And a lot of times it's trigger points, and it's not what we just see just because we run imagery, because the imagery sometimes puts us down the wrong path. It could be super useful, and it could also just be a thing you have that's not why you have the pain. And then we spend so much time on stabilizing and traction, and it's not going to help that glute medius, right? Which is one of the butt muscles for a less technical term.
Yeah, absolutely.
Okay, so let's dive in a little bit deeper. I'm going to talk about this for my own selfish reasons. Right now, I think I'm self-diagnosing with, I think I have a trigger point in my hip flexor.
Mm,
Tell me, like, if you, or maybe we should go about this a different way. So I have pain anytime I engage hip flexion on the right or lumbar flexion. And so I'm trying to like self-diagnose
mm.
whether this is a disc issue or do I need my hip flexor released? So what kinds of things would you expect to see with like a trigger point in, the psoas release? You hear a lot of people, you won't want to do a psoas release. What would you expect to see with that?
So, a fair warning, I can talk for like an hour about the psoas, and I won't. I won't. But
Okay.
psoas is so, so important. So, to back up a little more, because we talked about trigger points having hallmark pain patterns. What I would say, I mean, the easiest way on the internet, you can go to triggerpoints.net, I believe, and literally you can pick on the area that you feel the pain, and it'll have the little maps, and it'll tell you the muscle, and then you find a little X because X marks the spot, right? And push on it. So if you've got a tennis ball, depending where it is, and if putting more pressure on there starts creating that radiating pattern, you have an active trigger point there. So we now know that's part of it. But the larger question in trigger points is why do you have it? You're not supposed to get trigger points. So it really becomes those biomechanics of what is creating that trigger point to form in the first place. So just releasing it might take away that pain, but then it keeps coming. Second to your question, Becky, um, we have two categories of trigger points that we look at now. There's technically three, but we've kind of thrown that out now. No one really follows it. There's what's called active and latent. Active trigger points are the trigger points that are giving you pain at that moment. Latent trigger points are ones that are found in the muscle and only when elicited, pushed on, or otherwise creates pain. You may be bending and stressing a muscle in such a pattern, a way that a latent trigger point now becomes active because there's enough pressure on it, and then you feel the pain. So the first thing to do, I think, is really to look on those trigger point maps, press around, and see if you can recreate the pain. And if that's the case, then you could wait and through what we say ischemic compression, softening, holding a self-myofascial release. There's a million different ways. Or good deep tissue massage, probably the more pleasurable way, and let it release. But then you have to identify why does it keep forming? Because that tends to be the thing. Our necks, trapezius, I talked about that before. We all have stiff necks, right? And it always is forming. But think of our, what we say, flexion addicted society, how we sit, our cell phones. I'm sitting at a computer right now. We're always rounding our shoulders. So there's always a duress on the neck.
Very interesting. All right. I'll have
You
to,
know,
so you said triggerpoint.net was
yeah,
the
trigger
that,
points,
that people
plural.
could go to. Okay.
Yeah, and honestly, they've been around. Janet Travell, which was JFK's doctor in 50s and 60s, she's was like the foremost expert, and her stuff is all over. I mean, a lot of that stuff is probably entering common domain at this point. So, yeah, Googling trigger points, you'll find those patterns everywhere.
Cool.
It's it's really interesting because they are the same. It is like a map. It's like a body map, and they're the same no matter what person you're working on for each condition. They have this same trigger point in the same place for that condition. And so it's crazy how they manifest themselves the same exact way on each person with those issues.
Mhm.
Yeah, and there's been a few studies recently that there's a 90 to 95% correlation between trigger points and acupuncture points. And Janet Travell and Meisner, which was the person prior to her, got interested in this stuff because they were like, well, what is this acupuncture stuff? It seems to be working for pain. And then they started playing around noticing this other thing, and then they started documenting the trigger point phenomena and moving from there, which is kind of where we fall into what my main focus now, what we call dry needling, which has gotten a lot of adoption in PT, some of the medical professionals, and there's a lot of questions about scope of practice and all these things. I don't get involved in any of that stuff. People that are well qualified to treat people. Um, Whereas essentially using a needle to gently enter, and these are very small needles, they're acupuncture needles, to enter that area and cause that not to release. Because sometimes we'll work an area repeatedly through manual therapy, massage, self-myofascial release, which is all wonderful and doesn't release. And in my clinics, we work in care plans, and that means with PT. And I didn't know at first. We just figured let's have everyone in-house when we want to treat people. That's a good idea, right? I didn't realize how effective it was for the PTs to have an area released and then have them go back to PT because they were able to get results so much quicker. Especially some areas that are just hard to reach.
Mhm.
Deep gluteal muscles, things like that are very, very hard to release, where small needles can get there. Pectineus groin pull, super hard to release manually and kind of uncomfortable, but very easy with a needle.
I'm glad you touched on the dry needling versus acupuncture because I get that question a lot when I go to dry needle someone. They said, well, how is this different from acupuncture? And my explanation to them is that we're very similar in what we're treating, in that the dry needling, we are looking for trigger points, we're looking for tight muscles that we're trying to get to relax. Where with the acupuncture, we are looking at more of the acupuncture points and trying to free up that flow of energy. Is that kind of how you explain it, or how do you explain the differences to people?
So, fair warning, you're asking a person that's spent a little too long contemplating this question. Um, So, I mean, without getting into the history of acupuncture and stuff, we have forever said there are spots on the body that are not points, but if there's pain there, you put the needle in, it goes away. And we have a category we call ah, sure, which literally translates as ah, yes, this is the location, this is the place of pain. Um, a dry needling is an evolution or a modernization and a redaction of the system of acupuncture, and just a subsect of it used solely to treat pain. And it has evolved to incorporate a lot of more biomedical understanding. And my 2004, no, 2003 paper, I did a correlation between acupuncture traditional techniques and dry needle techniques, all of them that are out there being taught. And there's a very strong correlation between techniques from 3,000 years ago and now. We're still doing the same things, but it becomes the language we're using and the framework in which we approach the person. But medicine's supposed to evolve over time, and no acupuncturist treats like it was 3,000 years ago. That would be very scary. There'll be no clean needle technique or anything else. So I think they're one and the same, but it's really the focus. And you're not gonna use dry needling necessarily for allergies, right? because it's not the right approach. But we could use acupuncture for it because then we're looking at different ways of regulating the body. But when you're dealing with muscles directly, that's dry needling.
Yeah. So you basically what you're saying is that it's more the intention for what you're trying to accomplish, basically more so than the.
So, I mean, with acupuncture, we would traditionally and historically do what we call dry needling now, but we may also include what we say distal points. And these would be points to what then goes into regulate the meridians. And these are more complex ways of balancing the body. However, I'm working on a book right now with a colleague where we're looking at what we say traditionally sinew channel treatments, which are the fascial lines which were written out in one of our old books that's about 3,000 years old. So we were talking about this stuff back then, and we didn't have a full grasp of it. We used very poetic language. But I feel they're one and the same, but there is that intention and that focus. And, you can go to a PT that's well qualified and learn the technique correctly. And when they're staying within that realm of musculoskeletal, which is the domain of a PT, it can be done very effectively, but I wouldn't go to a PT for my allergies. That would be strange, right? So, and the acupuncturists, and believe it or not, acupuncturists are trained as general practitioners in school. I teach in one of the programs, and you have to specialize. So they're okay at musculoskeletal. They're okay at everything. But for musculoskeletal pain, you really want to go to the specialist. So you want to find people that are well qualified. And I think that's what it comes down to for good healthcare these days.
And we have our audience is pretty familiar with acupuncture. I know a lot of cowboys that go and get acupuncture, cowgirls, and have had a ton of success with it, especially those who have a hard time finding the answers they need from just PT or anything like that. And so, and once they find something, that is what they do for everything. And Becky could touch on that too, but. It's interesting you bring up the allergies because the acupuncture stuff and how it can affect like organ function, maybe even emotional type release stuff is very, very interesting.
I mean, it's super interesting. And, I'll even steer it right back into musculoskeletal when you're talking about somatic release. A fairly famous PT, John Barnes, which I'm sure some of you guys know of him from the myofascial system approach. He used to say the issue is in the tissues. The idea that the fascial system, the muscles, especially muscles that are injured, like let's say you fell off a horse, right? And stay there. And, a muscle tightened down, right? That fear may actually be still somehow, and they're still studying this, trapped in that muscle. And when that muscle finally releases, which might be months later, right? You suddenly have a flash in your mind of falling off that horse or the car accident or anything else that happened. And it could even not be physical trauma. It could be you tensing down through a traumatic experience, a terrible breakup, a death of a loved one. So we see these somatic releases that can happen in physical therapy or happen in just coming for neck pain. And that's where we start saying, like, how do you draw that line between acupuncture, PT? There's medicine and there isn't, right? It's either people start getting better or they're not, right? To say, well, as soon as they start crying, well, you have to go to the acupuncturist because now that's weird, right? Like I don't think like that. I really think I'm very patient focused in clinical outcomes. And I think the integrative approach of thinking about what is that wider umbrella? How can we learn from these I don't like the word alternative systems, but these things on the periphery, that's not what we say part of the system of care, right? You go to the hospital, no one says go get acupuncture, right? You're lucky they'll refer out to PT, but the insurance industry is going to give you 10 minutes with that person. It's terrible what's happening. So we need to kind of expand what does care look like and take the stuff that works and make sure it becomes part of the appropriate care for people. Instead of giving someone an SSRI because they don't know what's going on, maybe let's look at their body as a whole and say maybe the diaphragm's not released and maybe they can't take a deep breath and maybe that's affecting their emotions. And the moment we can release that through structural changes and other things, and proper counseling, we can make huge changes instead of just using a medication.
I agree that integrative approach is something that does get missed because practitioners will put themselves in boxes. and then they won't steer outside. Something weird happens, and they're like, "Oh, I don't know what that was," or something isn't getting better. Like, well, you're not doing and they put it back on the patient instead of trying to figure it out and dive deeper into their history on what could be going on.
Yeah, no, I agree. And it comes to training and everything else because we're trained in this standard of care. All of us go, and I always joke that our board exam, the exact language is it's a minimal competency exam, as most board exams are, right? And when you use that language and you phrase things that minimally competent, oof, it kind of sets that framework. But that's what a board exam is. It's a minimal competency exam. So, practitioners really need to be encouraged to continue to grow and learn from each other, right? That's why, I love being on a show like this because I'm going to learn from you guys about things. And I love working in integrative settings. And, even in Brooklyn here, I have friends that are PTs that are very focused, graduates from specific programs for pelvic floor health. And working with them is incredible because I don't want to do all those things. It's not my specialty, but I need to know about those things so that I can talk that language and create a proper care team for my patients. They might only see me like 4 times if it's just for, dry needling, because it's pretty effective. But
Mhm.
if they don't have a care team and they don't have good people around them, they're going to keep coming to me because it's going to keep coming back. They need PT, they need structural change, right?
And that recognition of those things as well. You may not be a pelvic floor specialist or whatever like the next person, but the recognition of those issues, instead of writing it off as, oh, you just have a groin strain or a hip flexor deal or whatever, when it's really something going on in the pelvic floor and those intrinsic muscles in there.
So we keep saying pelvic floor, and I realize we haven't even said what the pelvic floor is. And I actually take a wider definition that's really to your point, Destry, that so the pelvic floor is really the muscles in the basin of your pelvis, right? If you think of the pelvis like, your hip bones and everything else like a bowl, there's a bunch of muscles down there that most people can't name or articulate, and you can't really feel them, but they do a lot of things. A lot of things. And when things go wrong there, you can have a lot of problems. But I actually take a wider view because when I first got into pelvic floor things, I didn't know much about it, right? Just like everyone, you're like, I don't know, I study these muscles in school, but like I can't touch them, so they're not important to me, right? That was my view, minimally competent, right? And I had people coming in with stress incontinence. I remember my first case was, I think, adolescent that had urinary leaking, um, you know, and no one, the urologist, no one could figure it out. So they come to acupuncture because that's what you do. You come to the weirdos, the people like, I don't know, maybe this will work. And I'm like, what the hell am I supposed to do with this? Right. But, I was very interested because, here's a person who's just growing up. I think she was about 14, and self-identity is formed at that point. You start dating, you're playing sports. She was very active and everything else, but now you have to wear a pad and you're leaking, and that really affects how you can grow as an adult. And there's a lot of like deep-seated trauma that can form there. So I was like really concerned. Um, when I looked and I just did basic biomechanical exam, she's super hyperlordotic, like excessively hyperlordotic. I was like, oh, okay. Now, mind you, I still didn't know much about the pelvic floor. I understood certain muscles were there, and I'm like, there's got to be some sort of pressure. And it was stress-based incontinence, right? Which means that, some sort of load-bearing exercise, laughing, coughing, etc., creates small leaking. Um, so I just started treating what I see, right? So I was like, okay, we need to reduce this hyperlordotic curvature, this like increase curve in the back. I'm trying to think how for people that are listening, how we can talk about that.
Like a
Uh,
swayback horse, we call it.
yeah, okay, sway back horse, we would say duck butt, like if you think of Daffy Duck, right? Or Donald Duck, it's like a big curve. Um, and her psoas was so tight. So I spent so much time on the psoas. But then the way that I treated the pelvic floor is, well, I'm still thinking at the quads, rectus femoris pulls at the ASIS, right? Pulls on the hips and tips it forward. What are these other intrinsic muscles? Thinking of, lower cross syndrome from Dr. John Doe, these kind of concepts of how muscles are interrelated. all of that is part of pelvic floor. If you're coming for pelvic floor treatment, it does not mean that we're going into more intimate spots all the time. It may mean that, but it's about everything that's interrelated. Through treatment, I was able to reduce it drastically. I didn't get to a curative, but the quality of her life was massively improved. She was able to really play sports. Normal activities really wasn't bothering her. It was only under like extreme duress, heavy lifting, stuff like that, that she would have minor leaking. And if I knew what I knew now, like I wish I could follow up. That's going at like a decade or so ago. The things that I would do now, right, I feel like I could have helped her so much more. But that's when my interest started happening. And then I started seeing weightlifters and then men who wouldn't talk about it because they don't even know pelvic floor health. We don't talk about that, right? For women, it's a little more common because childbirth is one of the major issues, especially vaginal delivery, that will stress those muscles down there and then creates a host of issues. Well, men, we don't have that, but men, we're pretty dumb. We'll go lift heavy things and think it's a good idea to do 400-pound squats. Well, that has an effect on your pelvic floor health and how it functions. So starting to talk to males who are coming mostly for orthopedic complaints, and realizing, oh, they have certain defecation pain, sensation issues, penile sensation issues, numbness at the perineum, the space between the anus and the testicles, pudendal neuralgia, and things like that. And it becomes very easy to help.
I think just I mean just simple knowledge of, because I've referred to a pelvic floor therapist before, and then when I met her, my mind was blown, and she helped me so much with understanding females more, because they got a lot going on down there. I mean, they have organs and muscles and all the things that pull on different areas that aren't necessarily muscle related, and like stuff going back, attaching to their um, sacrum from the uterus, and things like that. I mean, there's so many things that can get off kilter in there, and she really opened my eyes to a lot of things. But as far as men go, it can be as simple as like how long a person normally should urinate, and was it like about 8 seconds should be about normal. Anything under that, I mean, and the frequency of it and everything else, you might start to kind of pay attention to that. And it doesn't mean that you got prostate cancer or anything crazy like that every time. You might want to get that checked out, but it could just be that your pelvic floor muscles aren't doing their job like they should. And then there's also the other issue of people who kind of overdo it on the Kegels and everything else, and they become hypertonic instead of, just normal function.
So there's two things that I would love to talk about there. One is one of my areas of fascination because I'm like an ortho geek, right? That's where I geek out. Is that mechanism of urinary voiding, right? Complete urinary voiding. And I'm really looking into and like studying kind of the neurological pathways and looking to say we have this concept of reciprocal inhibition, and to make that simple, it's like when one muscle's tight, if you're putting your leg forward, you're contracting your quads, the hamstring has to soften, right? These are neurological principles, right, that happen when a certain area is tight. I'm starting to notice that what we call the vata ani, which is the kind of the muscle that's in the pelvic floor. It's really like three separate muscles that creates one like wide thing. When that is tight, I believe there is a certain pseudo-reciprocal inhibition to bulbous cavernosus or spongiosus, which is the muscle that's responsible for voiding and squeezing on men and women the urine out all the way. And then when that muscle's tight, there's also an inability for the urethra to have a full sphincter to be contracted fully, so you can have leaking and voiding, or these other things that are going on. And it's way more complex than that. But there's this whole host of stuff that's going on. And additionally, these muscles are responsible for keeping organs in place, the bladder, the urethra, and for females, cervix, uterus, etc. And when these organs aren't being able to be held in place correctly with the right tension, it starts putting pressure. So the uterus can start putting pressure onto the bladder, etc. And that pressure creates urgency and all these other things. So it's a whole host of or a cascade of things that can go wrong.
Mhm.
Definitely. You mentioned pudendal neuralgia a couple times, and that's something that we've seen in our population. I know you see it in the bike riders up there. Touch on what that is and how you like to treat it.
So the pudendal nerve is a nerve that's basically it innervates that muscle. We say levator ani and branches innervate several other things in the pelvic floor. And by its pathway, it can get entrapped by certain muscles and certain tunnels that it has to run through. And it gets entrapped. Entrapment essentially is just an issue of muscular tension. And if there's long-standing injuries, you could also have fascial entrapment. So to backtrack a little, you mentioned Kegels. Kegels makes the pelvic floor tighter, right? But if it's always tight and can't relax, we have a lot of these issues of what I talked about, reciprocal inhibition and everything else. Tension of that pelvic floor could push on the pudendal nerve, creating numbness, improper innervation of certain areas, painful intercourse, or lack of sensitivity, penile sensitivity, and things like that, aorgasma, urinary issues, et cetera, et cetera. The way I like to treat it as a dry needler, this is where that difference is between a PT who's going to be much more holistic and systemic, is I can go specifically into those muscles and tell them to instantly release, right? By entering and finding the trigger point or what we call motor points and other neurological areas that I could touch ever so slightly that causes that muscle to release. And then we can get to an actual relaxed state where we see changes. That's where now rehabilitation really, really starts. Because one of the other things is there's a relationship between your diaphragm and the pelvic floor, or what we call the pelvic diaphragm, right? And they do a dance between each other. So when you inhale, the pelvic floor should release. When you exhale, the pelvic floor should get tight. A lot of us don't breathe correctly, or we have such posture that inhibits our diaphragm. And I can see this on my bike riders. I can see these in my athletes, and I'm sure you see it in horseback riding. And I'm thinking, and I don't know much about horses, but I had a friend that really like drove home the different styles between, English and Western style, but like keeping that core really, really tight. And I rode a horse once. So you have to keep that core tight if you want to stay on the horse. That affects your diaphragm. And if you're not taking those deep, deep breaths, other than its systemic effects of anxiety and everything else, the pelvic floor never fully releases. And then you go do your Kegels because you think that's going to help you, and you just keep making it tighter and tighter and tighter. But it's about a dance, right? And you have to have both the ability, health is the ability to contract fully and release fully, right? So that's kind of like how I see it. And for pudendal neuralgia, it's really making sure that we can release the pelvic floor, and areas that don't want to release, we go in there and we'll release it specifically.
What are some of those muscles that you see entrap the pudendal nerve that, I mean, are pretty
The
common?
major, yeah, the major one is obturatus interns, right?
Yep, yep.
That's like the main one because it runs right through there. After that, it tends to be issues of compression more so than anything, and it's really more that pelvic floor fascia that's making it too tight, and there's certain tunnels that nerve travels through that just starts creating compression. But treating that obturator muscle makes a huge, huge difference, and it's fairly easily, especially with dry needling, easily accessible. And what's really great is people can start releasing that on their own with a tennis ball and everything else. And if not, there are other manual techniques that can do it. And by releasing that alone, it creates a release through the Vata ani, which is that entire pelvic floor, because the nerve innervates that muscle, right? So we start looking at these pathways. That makes a huge, huge difference. That's why you really need people to start understanding the body as a whole of what's happening, right? Because you can do all the deep breathing you want, and Levedana might not respond because that one muscle is just trapping the nerve. So it just doesn't have the right signaling.
That's one of the things that I feel like gets overlooked is how hip rotation is affected with specific things, and specifically hip internal rotation, I feel like is a major deficit in most people, and that's why they have trouble getting a deep seat in the saddle, getting deeper in the squat, and things like that. But if you can open that up, it feels completely different.
Well, if you do gait analysis on most people, myself included, my gait is not where I would like it to be. Well, we say that the nutation and the ability for both iliums to move correctly in a proper stride is impaired so much on people. You have SI joint dysfunction. We hear that all the time. Well, SI joint dysfunction means that that one ilium is not rotating correctly, but we're still walking, which means somewhere something has to give more. And you'll often see that either people will do like they'll swing their leg around, or they're using quadratus lumborum, their lower back muscle to hike that hip up. And then that sets off a cascade of stuff. But ultimately, that means there's no motion in the pelvic floor. And the treatment partially is to release whatever is preventing that from moving. Could be psoas, could be QL, could be an ankle issue because the immobility of the ankle changing that kinetic change, that kinetic cascade, right? Or tight calves, which is throwing off the entire pelvis, right? So you don't have to be a pelvic floor specialist to really affect the pelvic floor. And a lot of my treatments is looking at that wider integrative perspective, which I implore people to do, and we can do on our own. You know?
Mhm.
Definitely. I think the ankle gets overlooked so much when treating hip pain.
Yeah, yeah, it's huge. Yeah, I mean, anything that, like when you step down onto the earth to move, if those th anything that contacts it and moves all the way up into your hips, if anything's off, your knee, anything else, it's going to affect how you move, and it's going to affect the hips, and it's going to affect your back, and eventually affect your neck. You know, the
Mhm.
body is a whole, and if we're just treating like neck pain, just by treating the neck, you know, unless it's acute and you slept weird on your bed, it's silly. It's not good medicine.
Mhm. I talk about this so like every time I eval someone because they may come up to me for neck pain and I have to explain, okay, I'm going to look at your pelvis because this is like the foundation of your house, and if it is off, then that's what's creating everything above there to be off. And so we could treat your neck, but if we didn't address the things below there that are creating the problem, then it's only going to be a temporary fix. And so, I think it's so important for people to understand that. And I think I love the approach that the integrated approach where we're looking at you as a whole, but we're working with other people to help improve your overall health and alignment. I'm very glad you brought up the whole tension of the pelvic floor, and if we create improved posture, it doesn't mean you just stand up straighter, okay? That's what everybody thinks, but that alignment, that getting your pelvis to move the way it's supposed to and be symmetrical on both sides. Most people aren't symmetrical on both sides. If we take 100 people, I bet 90 of them are going to be asymmetrical or they're going to be out of balance. And so, but when you get everybody in balance, then the muscles can work the way God intended them to. They're the most efficient. And so, like our program that we do for pelvic pelvic symmetry, our postural restoration stuff that we do is so helpful for that. Years ago, I had a gal that she was chronically constipated.
Mhm.
That wasn't why she came. She came in for like back pain. And after we got her pelvic alignment better and her pelvis neutral, she commented to me, she goes, well, I don't have the chronic constipation anymore. And she goes, and so I gave these exercises to my sister who also was fighting with that. And she's better now too. And so it was like, woohoo, a little surprise for me as a practitioner. This was like 15, 20 years ago. That, when you get everything where it should be and the muscles balanced out, everything is going to work better.
No, I fully agree. And I mean, from that, you can be talking about the nerves that come from the lumbar spine that innervate the bowels and everything else, and there's too much pressure on it or entrapment. There could be pelvic floor dysfunction, affecting the way that defecation occurs and triggers for defecation. There's so many things, but sometimes we don't really have to think. Like we don't have to target the main things. We look at the structure, we bring them closer to balance. And I often say sometimes millimeters of difference makes a huge difference because you just need a little more room on a nerve or a little more room for a blood vessel to start innervating. and massive changes happen. So I try never to get people obsessed with their symmetry because we will never be symmetrical. And I've had that happen with patients where I'm like, oh, look, this is not like that side. And then they get obsessed. And I look in the mirror, I looked and I was off again. No, we're always going to be off. Right. I'm sitting in my chair right now in probably one of the worst ways possible, which means that one hip is being more favored than the other. Think when you get in your car, a lot of us slide in with one hip. That's how you get in. And then we never correct ourselves in the seat. So one hip's always a little more forward. And then we're torqued. And then we might sit there for 3 hours driving, right? We're always in these asymmetrical patterns. But as long as we have a good amount of flexibility and our body can move correctly, we should be fine.
Yeah, and muscle balance, that you don't have one set of muscles that's too tight or too dominant, which then, as you talked about earlier, then that muscle that's opposite of that is always going to be inhibited or weaker. So we got to be able to balance that out. So because we're moving beings, we don't just sit in one spot and we are active, we're moving. We want to be able to move. So we got to be able to move in and out of different positions and be able to maintain throughout that.
That's a big thing too, especially in sports. And I'm curious actually if you see that. I know you're involved with like rodeos and everything down there. Is there like favoritism to the side? Because I know with like tennis players, baseball players, especially if they're a pitcher, they're hypertrophic or overdeveloped on one side. And that leads to a whole host of issues. And that can actually throw the pelvis off from the pulling of the shoulder. I'm
Mhm.
curious if that's something that's happening, in rodeo. Are they favoring sides or, I'm
Yeah.
not sure.
So well, I feel like part of it is just our whole postural things, but like I don't know why we all decided that getting on the left side of the horse was the only way to get on a horse. They always step on your left foot is always the one to get in the stirrup and lift yourself up there. People that are maybe a little more conscientious of their horse will sometimes get on the right side and switch it up. But, the majority of people do everything on the left side of their horse, or they always bridle their horse, with their right arm up above. And so, like, yes, there's definitely patterns that we see. And I think a lot of it has just evolved because that's the way that their grandpa taught them how to do this with a horse, and so they even call the left side of the horse the near side and the right side is the far side. And so yeah, there's definitely some asymmetries that start because of the traditional way of doing things, and then it does create an imbalance in the rider and an imbalance in the horse as well. So it can be an issue for sure.
That's fascinating. I knew I was going to walk away learning more about horses and stuff because that stuff always fascinates me. Because, humans, we get stuck in patterns of repetition, and sometimes that becomes an issue. It's like, how we enter cars, how we apparently get on horses, how we sit on the couch. I've become now where I alternate the side of the couch I like to sit on because it's like when you sit on a couch, I don't sit upright. I lean. We all lean, right?
Mhm.
So I started realizing that I was creating patterns in my body of leaning to that one direction. My shoulder was always being elevated, therefore the clavicle started getting a little misaligned. Same thing is like if I alternate sides, I alternate my leaning and I create balance. So probably the same things, getting on a horse differently might be good for you and apparently the horse.
Yeah. And I tell people too, like it's the little things that either keep us out of balance or the little things that can keep us in balance. So, like you said, just being aware that how you always sit, do you like shorter women, they will always sit with a leg folded under themselves, and then they wonder why like the front of their hip is like hurting, and so once they can become aware of some of those things, then you can start to change it. It is hard to change those habits, or even, our handedness, or right-handed. If you're always reaching with your right hand, your body's always rotating with that right shoulder forward because you're going to be reaching with that. So, alternating how you reach, or, you're reaching for your water glass, try to reach with your left hand every once in a while. I always carry my purse in my left hand so that my right arm is free to reach to open the doors. try carrying your purse on your right side and make that left arm do the reaching. Just really little things like that that can make a really big difference in your life.
I fully agree. And I have this huge bag that I carry when I teach. And I carry it onto the subway. It's the city life, right? And I always put on one side. I don't know why. That's the side that feels comfortable to me. And I'm like, this is not good. I feel my shoulders starting to drop and get pulled down. I'm like, I should wear it on the other side. These simple changes, though, can make drastic changes in our health. Like you said, even from constipation, right?
Yes,
Yeah, it's huge.
for sure.
And our bodies are not made to be symmetrical anyway, with how, like, the right side has the liver and stuff. So those organs are heavier on the right than they are the left. I mean, we're in that way, we're not made, we got two arms, two legs, same muscles on both of them. But other than that, we're not really made to be symmetrical 100%. And for some reason, and this is a little bit off of that, was, when I look at people, whether they've been riding or, different sports or whatever, it always seems like the left hip flexor is more locked up than the right, or the left hamstring is tighter. There's something going on that left side that I haven't quite figured out yet on why that left hip flexor is so toned up on most people.
I've been really into adductors for a lot of that stuff because and I think it seems to be the hidden play in both SI joint dysfunction, sometimes locking of the hips. Because you think that angle of direction, right? Those are the muscles that are on the inside of our leg. They attach at the inferior rami of the ilium, and they're pulling, right? And that pulling can actually just tilt and lock up everything. And then you start seeing the hip flexors and everything else bind against it as a stability, often on the opposite side. So if you have a left adductor, the right, let's say small glutes might actually become tight. And we don't think to check the groin of the other side, right? Just because it's not something we're thinking of. But there's all these little symmetries and it's three-dimensional. And then the question is, why is that adductor getting locked up? Well, maybe we're walking weird, or maybe we're actually not wearing the right shoe support or arch support because we have no arches or something else, right? And it's an endless game, but I think it's fun.
It
Yeah.
is fun to try to figure out.
Yeah, because you don't have to get it right. You have to just get enough of it right to make changes. And
Exactly.
like you said, the diaphragm itself is imbalanced between left and right, which
Yes.
inherently creates an imbalance in our body and in our structure. So yeah, we're never going to be symmetrical. We just have to be flexible in our in symmetry.
Yeah. Well, I feel like we could talk for hours on this subject and we could totally geek out and lose all of our listeners on it. But I
I
really
apologize.
no, 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 this is awesome. It really falls in alignment with the things that Destry and I do, and so I appreciate Dr. Barber. We'd never met you before, and so it's really cool to have somebody on the other side of the country that is like-minded in how you go about treating people. And I appreciate having your perspective on this, and it's really interesting. So I would love to have you back again to talk about some more things that you see in regards to chronic pain and pain management kinds of things, because it is such a huge issue. And if people can, just start to make some little changes in their life that they can, start to manage to get more pain relief, less medication use, things like that. I really feel like that's our audience really wants to be able to get themselves better without just having to pop a pill. And so, I appreciate what you do for people and your willingness to educate them and be on a platform like this so that we can help spread the word more.
Becky, you've taken a lot of words out of my mouth. I am so excited to share this stuff with people because for me, it's about raising awareness. Yes, I have a practice, um, and I love treating people. There's only so many people I can treat, and I'm not the best in the world. There's so many great people out there, but getting that awareness, getting that message out there, especially in the face of the opiate crisis and all these other things, it's like pain is across the board the one thing that everyone's going to deal with at some point in their life.
Mhm.
And if we don't have educated consumers or patient population, they can wind up in a very dark place,
Mhm.
suffering, which
Mhm.
affects marriages, relationships, work, income, and then especially, opiate addiction that can come with it. So I'm so excited to share this stuff with you. I would love to talk. As you can tell, I am a complete nerd about this stuff. I will go on forever as long as your audience isn't like, oh my God, Jordan is, I have no clue what he's saying it, but it sounds fancy. Um, if that's the case, I apologize. But yeah, I would love to talk again. This has been a wonderful experience, and I have learned some interesting things about horses now, so I'm happy.
Wonderful. Wonderful. Well, thank you so much. Destry, do you have anything else that you'd like to add or?
Oh no, I mean, you guys covered it, and I think that it's just so important that people will realize that just because you've talked to one practitioner and they have their approach, there's so much more out there for you if it didn't help you. I mean, you can't just be like, I've been to PT and you've been to one dude and they didn't help you, so you just give up. No, no way. Keep going. Keep trying to find that person that's willing to advocate for you or use their network to get you to the right hands and get you living a way better quality of life than what you could imagine from the pain that you're in right now.
Amen.
I agree. Well, I appreciate everything, and if anyone's ever looking to find me, drjordanbarber.com or drbarberclinic.com or jbarberlac on most socials. Somewhat active on social, but you can always message me on there, and I'll probably respond. So.
Great. Well, I appreciate you bringing that up. And one of the titles you have is healthcare consultant. Do you usually consult more with the practitioners or like a patient that is like, I don't know where to go for help or both?
So I do a lot of practitioner consultancy. I'm probably calling it coaching more these days. There's a lot of good consultants if you want to do, structure and as far as like, your income and how you want to manage the business side of things. But
Mhm.
what I realized, and I published a book actually about 3 weeks ago called Realigning Medicine, available anywhere. And it's really focused on being happy as a practitioner and following the mission, the reason why you became a practitioner. Because I find a lot of solo and small practitioners struggle because there's this behemoth of a system and they don't know how to get themselves out there. So they start just doing whatever they think people want. And that's usually not right. So I really try to help practitioners flourish by finding themselves and instituting those in very logical business minded ways. And then you can get the consultants to do your structures and your accounts receivable and all your fancy stuff because that bores me. That's not me. I like to wrap my head around the complex stuff. So I do that. I do a little telemed for functional medicine stuff. But I'm sparing with that because I want to make sure that I get outcomes. There's a lot of great telemed people out there. But if
Mhm.
I think I can help the person, then I will do it. So,
Mhm. Well, I appreciate that. And I loved the name of your book, Realigning Healthcare. Um, I think our healthcare system is broken in so many ways. And part of it is, the it's such an insurance driven, you have to see so many people in order to keep the lights on, to keep a profit. And so yeah, you as a practitioner, your passion and the reason why you went into healthcare can really become stored in the back of your mind because there's just so many either quotas or things that I always call it like all the shit that gets piled on top of you. You cannot see daylight because just all that shit is there. And so, like once you start getting that crap away, you can actually remember why you did what you did. And so, and part of the reason why I have sold my practice and am just doing cash-based pivot point stuff, it really aligns with my passion and my mission now in life. And I really hope more healthcare providers can get to that point because I really do feel like people go into medicine for the right reasons. And a lot of times it's the system that kind of ends up breaking
It's
us.
death by a many cuts, but it comes to mission and purpose. And, I have a boutique practice that's cash only, and my practices out on Long Island do take insurance. And the one thing that that upsets me is that all the good people like you, Becky, right, wind up in cash because we don't want to deal with it anymore, which means that people that don't have money have to get poor service. That's not right, right?
Mm,
So it's like it upsets me, but it's the only way I can see people. So now I'm starting to think, oh, how can you give back? How can we help people? Because healthcare is really between the provider and the person. The rest of that system needs to go away. So how can we deliver effective care in a way that makes sense where providers can pay off their loans and still live? And I don't have all the answers, but the more we get providers educated and are really determined to help people and give the appropriate time and care, I think we'll start seeing changes naturally evolve out of that because people will want good care. They won't want bad care.
I
And
agree.
there's so many people needing help, and I think, another part of that alignment is between healthcare providers and s- them not focusing so much on competition and competing with each other, but collaborating with each other to get people better. And that's why I love that you're on here, and it's so great to talk to a like-minded person with your approach and everything else to help people, because that collaboration is what grows the profession, in my opinion. And so, and that's what gets people better, is sharing this knowledge and having this approach to, do whatever is possible instead of putting yourself in a box. So it's just so refreshing to talk to a like-minded person, even though you're clear across the country. So
Yeah, no, and there's a lot of us, and I think we just need to get louder voices. And I just want to be one of those loud voices, and I think we can do a lot. And I'm so glad to meet you guys. And I would love to geek out more anytime you want.
same.
Good.
All right. Well, if that's everything everybody has, I thank you so much for coming on here, Dr. Barber. It has been an absolute pleasure, and thank you all for listening. As always, let your health be the pivot point to your success.
Thank you so much.